Hey folks, Professor Finn here, and today we're going to be looking at Chapter 17 in your Embalming History, Theory, and Practice by Sharon Gee-Mascarello. Let's get the presentation shared, and let's talk about preparation of autopsied bodies. So, disclaimer alert, we're about to look at some graphic stuff. So, an autopsy is the post-mortem examination of the dead human body, and there are two types of autopsy: the medical autopsy, or the hospital autopsy, and the medical legal or legal autopsy known as a forensic autopsy. Most coroners and medical examiners do not want the body embalmed prior to autopsy. There are some pathologists that prefer arterial injection is done prior to autopsy, but no cavity embalming. And realistically, if we're looking at a legal issue, they do not want you modifying the body chemically with embalming, because that could destroy evidence. And clearly, we're going to be removing and destroying evidence when we bathe the body and do stuff like that. So, generally speaking, this is probably going to be around someone that's doing a private autopsy that doesn't mind if you do something like this. But when in doubt, no cavity embalming. In certain autopsies, particularly hospital autopsies, the family not only must give permission for the autopsy, but they can also set the limit to on the autopsy. So, if it is a legal issue, the state empowers medical examiners and coroners who order medical examinations to do whatever it is that they need to do in the furtherance of their official duties. When it comes to private autopsies, generally the family can limit exactly what it is that can be done. But just because it says here in the textbook that the families have the right to limit doesn't mean that that's going to be applied to all medical examiners at all times. When special instructions have been given, it is important that the pathologist follow the limitations established by the family. The partial autopsy may consist of external examination and or removal of only one or two organs. So how do funeral homes get in trouble with stuff like this? Well, what they end up doing is they allow the pathologist to come onto the funeral home property. They don't check to make sure that it's been authorized. They don't check to make sure that to the extent it's been authorized, and even worse, sometimes they actually assist with the autopsy. So a funeral director, an intern, a resident, an apprentice, whoever it is, will assist the pathologist in their examination, and then they will clean up the prep room, they'll embalm the body, etc. So it is very, very important that you double check and triple check with the family to make sure that they're authorizing one of these, what the extent is, and if you are participating in this, that you are ensuring that it's being limited to what has actually been instructed. The embalmer should document in the embalming and decedent care report the type of autopsy performed and the disposition of the visceral organs. So, under the hospital or medical autopsy, permission for the hospital autopsy is obtained from the person authorized to make final disposition decisions, or the generally approved term for this is the legally authorized person, whoever that may be. Hospital autopsies can confirm or verify a diagnosis, and your book lists several reasons why by the College of American Pathologists for the performance of a hospital autopsy. Now, a medical, legal, or forensic autopsy can be ordered by a coroner or medical examiner because they need to review some manner determination of cause, time, etc. of death. So there are numerous reasons why this may be ordered by the state in order to have this procedure. The cases that come under the jurisdiction of a coroner or medical examiner vary from state to state and from county to county within a state. So your book has a general list that represents typical cases that would be investigated. This is commonly referred to as the dirty dozen. And I'm not going to read all of these off. Generally, if it's not a natural death, then it's probably going to be reviewed by legal authorities. Now, this is a topic that causes some consternation with people. Death within 24 hours of admission to a hospital is not considered a reportable death unless it falls into one of the dirty dozen. So, just because you go to the hospital does not mean that if you die within 24 hours of admission that you are going to get an autopsy. So, For instance, I have cardiac issues. And if I was to go to the hospital and I was to pass away in the hospital 7 hours after I'm admitted, chances are pretty good they're just going to look at the totality of my circumstances, and if it even remotely looks like something to do with my heart, they're just going to attribute it to cardiovascular heart disease. That's just the way this works. So the following is a brief list of common reasons for forensic autopsies taken from your book. Determination will vary from state to state and within counties of a particular state. Again, the dirty dozen. So autopsies are defined by the extent of the post-mortem examination, and a partial autopsy is limited to a specific cavity or region of the body, and the incision is made accordingly. The complete autopsy examines the entire body. A standard Y incision is used to examine the torso or trunk of the body, and a cranial incision is used to examine the head. The complete autopsy involves full physical examination, I speak good today, tissue and fluid sampling, and removal of both the cranial and visceral organs for examination. And your book contains a rather full list of what can be examined. So, general considerations when working with autopsies. First, when not in use, remove sharp instruments from the embalming table. Cover sharp bones prior to placement of an embalmer's hands into a body's cavity, and the way you cover that is usually through a towel or a smaller hand towel. Wash gloved hands when soiled and change gloves often during the embalming procedure. So you should be double gloving, and when your outer gloves become contaminated or dirty, you should swap them out for cleaner so that you do not transmit bacteria or microorganisms from one part of the body to somewhere else where it could cause decomposition or tissue gas issues. Avoid high water pressure to flush blood and fluids from the embalming table. Practice continuous aspiration of the cavities during arterial injection to remove drainage and excess arterial fluid. Clamp leaking arteries and small veins to avoid excessive loss of embalming solution and to improve solution distribution during arterial injection, and run water over the table continuously to flush blood and chemicals toward drainage. Pack external orifices, and during embalming, the calvarium and sternum can be soaked in preservative solution within a sealed bag or container. A very common practice is when you are putting the viscera for preservation, typically in a bucket. You will put the calvarium and the sternum in the same bucket with the cavity fluid, so it is effectually disinfecting and preserving while it is in there. So with fluid strength, the magic question always is it a normal case or a complicated case? And if it is a complicated case, then you are going to increase your percentage strength of solution. You're going to use higher than normal index. You're going to be using restricted cervical or multi-point injection. And what is a complicated case? Anything that is not normal. And an autopsy case is not normal. So we are dealing with delays. Okay, delay may occur between death and autopsy, between autopsy, release of the body, and embalming. There are a lot of things that can go crazy with an autopsy, and there are some areas of the United States where it's not uncommon that the body is just left on a gurney outside of the examination room until it's their turn to get in for the examination. And they could be sitting there for an hour and a half, 2 hours, while things are being completed. Not saying that it's every place, but I have seen lawsuits where a body was left outside of an examination room for about 2.5 to 3 hours before the postmortem even began, which is a significant amount of time to be left out of refrigeration, especially in a hot, humid area. And if there is any sort of pre-existing problems with the body, they're just going to be exacerbated by that time left out. Mortuary refrigeration is routine before and following autopsy, and time delays often necessitate the use of stronger than average arterial solutions, so you are looking at something greater than 2%. Delay also brings about rigor mortis, and if long enough, the passing of rigor mortis. Rigor can cause poor arterial solution distribution and may also be a false sign of fluid firming. Fluid reactions with body proteins do not proceed normally when a body is in rigor mortis. And refrigeration can bring about hemolysis of the blood, which creates an appearance similar to that of the dye present in arterial solutions. In addition, refrigerated tissues feel embalmed because the fats in subcutaneous tissues have hardened. So use dye in your arterial solution to serve as an indication of arterial solution distribution. Keep in mind that dyes show only surface distribution of arterial solutions and not deeper tissue diffusion, i.e., dyes can lead to shell embalming because you think there is more there than there is, and the dye is making it look good. So make sure you are relying on the total quantity injected and observing how much is coming out as drainage. So if you are getting good color and you are a half gallon to a 3/4 of a gallon in on a 250-pound body, shocker, you don't have enough chemical in that body, and you are likely going to have an overexposure on your dye if they're already looking good at that level. Not saying 100% of the time, but pretty certain you're probably going to get some non-ideal cosmetic results unless you are looking to counterstain. So massage deep tissue, such as the muscles of the legs during rigor. There was a presentation at the National Funeral Directors Association here in New Orleans in 2024, I believe by Reagan Moreland, a popular funeral influencer and practitioner, and talking about the benefits of deep tissue massage for embalming situations. So massage is one of those popular things that people do. Intermittent drainage increases intravascular pressure and promotes diffusion of embalming solution and drainage of blood from the vascular system. With your pressure and rates of flow, tissues can assimilate only a certain amount of fluid in a given period of time. Often, arterial solution is injected too fast into the body and swelling results. Slow and steady wins the race. In preparation of the autopsy body, inject each section separately. In other words, you are doing sectional injection. And please do not ask me why the pen tablet is writing the way it is and why everything just disappeared, because I have no idea why. So we'll try this again. I'm going to try to write slower. That's not having much of an effect. Yeah, so we're not even going to bother with the pen because something is clearly wrong, but you get the idea. During injection into a specific body region, such as an arm or leg, higher pressures and faster rates of flow can be safely used to establish good circulation. And what they're meaning by this, remember, this is a full autopsy. So when you are injecting into an arm, whether you're using high pressure, high rate of flow, it's not going to flow into the head and cause swelling. If you are doing something like a partial autopsy, you want to be aware of what you are injecting and where it is going and being smart. The embalmer can vary the rate of flow and pressure for each area to overcome the resistances of a particular body region. Intermittent drainage and pulsation can be used for each area to establish good distribution and diffusion. Make a little note to fix that typo. During arterial injection, it is not necessary to insert drainage devices into veins. Drainage material will flow directly into the body cavities, and once in the cavities, an autopsy aspirator is used to evacuate drainage to reduce fumes and maintain visual inspection of the cavity interior. Autopsy aspirators are designed to not clog easily. Large holes are present at the working end of the instrument. Clamping the veins with a hemostat or applying digital pressure with a piece of cotton temporarily stops the drainage. Intermittent drainage and alternate drainage greatly assist in fluid distribution, diffusion, and retention of the arterial solution. So the order for treatment, the following is a recommended order for all autopsy cases, but ultimately it is your preference, it is your judgment that will determine the sequence in which you do things. So if you notice you need to treat something sooner rather than later, you may start with that. If you see that something is okay and you want to focus on some topical treatment somewhere else, you have the luxury of embalmer to be given the power to do that. In a lawsuit, your interpretation of how to proceed with the sequence will be scrutinized. You have been warned. So first up, apply a topical droplet spray to the surface of the body and orifices. This is just good old-fashioned primary disinfection. Bathe the body with germicidal soap and give it time to work. Relieve rigor, position the head and shoulders, and shave and set features. Remove temporary sutures and open the cavities. Remove the bag containing the viscera. Disinfect the internal surfaces of the body cavities with a topical spray. Locate and place ligatures around the arteries used for injection. So if you are looking around, With the full autopsy, you are looking for probably external iliacs. You are looking for anything down there in the legs. You are looking for something for the arms, typically the axillaries or maybe the subclavians. And finally, the right and left carotid arteries. Prepare the arterial embalming solution. Consider a variety of factors in determining the strength of the solution. Different solutions may be prepared for different sections of the body. If you're not picking up what they're putting down here, what they're saying is you can inject every single part of that body with a different solution if you are so inclined. Inject using rates of flow and pressures that meet the demands of the various body areas. Drainage may be concurrent or intermittent. Inject the legs, arms, and then the head. So start at the bottom and work your way to the top is the general order of, or the general sequence. Use supplemental embalming. Treat the trunk walls, the shoulders, the neck, and the buttocks. Treat internal surfaces with accessory chemicals. Use drying and hardening compounds or other preservative powders. Prepare abdominal and thoracic cavities in the neck area. Return the viscera or fill cavities with absorbent material. Saturate absorbent material with preservative chemicals. And contour the neck area with cotton and saturate with preservative chemical or autopsy gel. Now, it is important, real brief, I want to talk about this. If you are not returning the viscera to the body cavities, it is important to box that up and keep it with the body throughout the entire funeralization process. And secondly, it is important to fill the body only with commonly used items such as cotton, sheet cotton, or white sheets or something of that nature. You do not want to use anything that could be considered quote-unquote general trash. There was a lawsuit some years ago where the body was stuffed with newspaper that was not positively represented in the media. So you will want to represent, or you will want to use items that we use in the prep room that are considered dignified for that purpose. So bulk cotton, sheet cotton, along with white sheeting would be acceptable for that use over other items. Finally, suture all your cavities. Dry the cranial cavity, treat walls with preservative powder or gel and attach the calvarium. Then finally, suture your scalp. Perform your terminal disinfection. Apply glue to incisions of the thoracic and abdominal cavity. Select plastic garments as needed. Place embalming powders into the garment and prepare your paperwork. Now, I will not cover step by step the process and the preparation of the autopsied body. I will highlight some facts. During arterial injection, support the reflected scalp with cotton to avoid causing a crease into the forehead. The scalp can be returned to its natural position and massaged to assist distribution of the fluid through the scalp tissues. Secondly, shave the face before injecting the head, although shaving can be completed after injection if necessary. Nothing new here. This goes back to the general embalming timeline. We prefer to set features and shave prior to chemical injection. Same thing with autopsied bodies. Longer delays equals stronger arterial strength. Add dyes as tracers. Don't be afraid to inject each section differently to meet the needs of the section. The ideal vessels for the legs are the right and left common iliac arteries. I'll say it again. The ideal vessels for the injection of the legs in an autopsied body are the left and right common iliac arteries. Why is that? Because as you are injecting, the common becomes the internal and external iliacs, and if they are intact, the external iliacs are going to go into the leg and become the femoral and cause preservation of the legs. If it goes into the internal iliac arteries, it is going into the deep tissues of the buttocks, preserving the deep tissues of the lower back. This is why when we are doing an autopsy, generally the internal iliac arteries have been severed and they're very hard to locate anything that would be useful. So we have to go in with a hypovalve trocar or an infant trocar and inject that area separately, hypodermically inject that area separately to attain some level of preservation. Now, You can always use a pair of hemostats to grab an artery that has been cut deep so you can put in an arterial tube. So you can dissect away some of the tissue around it, grab it with a hemostat, and then insert your arterial tube and preserve what you can. Use supplemental embalming techniques in areas where distribution fails or is not sufficient. The embalmer should always use the artery closest to the center of circulation, even in an autopsy. If the arch of the aorta and its branches remain intact, use it to inject both the head and upper extremities. So what you see here in this picture is you see treatment using a hypovalve trocar into the flap tissues of a torso. And the reason why you need to do that is because all the collateral circulation that would preserve that tissue has been disturbed by the autopsy. So you are going to want to supplement your injection with a hypovalve or hypodermic injection on the tissue flaps. If you are injecting the arm from the axillary artery and fluid is not flowing down the arm, pull back on the arterial tube as it may just need to be repositioned. Remember, going back to the chapters where we talked about the different arteries, there's a lot of stuff going on in those armpits. There's a lot of little tributaries and side arteries, and you could be grabbing something that is not what you think it is. So if you back it out a little bit, you may find that you were injecting down one of those side tributaries, and now it finally has the access that needs to flow into the arm. Always inject the left side of the face before the right if you're doing them separate. If the eyes have been enucleated, loosely pack the orbits with cotton saturated with autopsy gel, and then close and pose the lids. If the ear has been removed, tightly pack the area of the temporal bone from where the tissues were removed with cotton saturated with autopsy gel. If a glossectomy has been performed, the removal of a tongue, you will likely have a distribution to the facial tissues. You will likely have distribution to the facial tissues limited or impaired. Your book gives you advice on what to do in that situation. So supplemental hypodermic injection. The embalmer can preserve areas of the trunk that did not receive arterial fluid by using hypodermic injection. Preservative solution is injected via trocar or hypovalve trocar attached to the embalming machine. Arterial solution or cavity fluid may be used for the hypodermic injection. Generally speaking, if it is a non-visible area, use whatever you have. If it is a visible area, you should be using cavity fluid. It is important that all tissues be channeled with special emphasis on the injection of the buttocks, breasts, shoulder, and neck regions. Surface embalming can also be practiced. The flaps can be separated from the ribs using a scalpel. The area should be then painted with autopsy gel. All inside surfaces of the cavities can be coated with autopsy gel. So one thing that we see here, and I am going to just change the pointer, is you can see right around here where the tissue was scraped away or retracted from the actual ribs, which we are now then going through with autopsy gel and painting those surfaces. It is very important that you are taking the time to do those things because this will increase your preservation. Cavities can be lined with cotton, paper toweling, or sheeting and saturated with cavity fluid before the viscera bag is placed in the cavities. Preservative powders can also be used, and care should be taken to pack the pelvic cavity so that there is no leakage from the rectum. There are a couple of things you can do there where you could tie off from the inside, the anus, so that nothing comes out. When you are putting in your cotton or sheeting or anything like that, you might first want to put in your viscera bag to see how much space you have to work with, and then pack on top of the bag anything to help fill out the rest of the torso. Now, there are multiple ways of doing this. I've even seen embalmers who just empty the entire bag into the cavities and then suture from there. I don't think that that is a good idea. You are exposing yourself to an awful lot of chemical when you could just go ahead and put the bag that everything's been treated in right inside the torso and be done with it. Return the visceral bag to the abdominal and thoracic cavities. Move the viscera within the bag until contents are positioned uniformly. So you can't just dump the bag in there. You're going to want to go ahead and make sure that you have a natural contour to the body. Incise hollow organs and release any gases, and add cavity fluid to the bag. Now, this is one of those areas where I kind of disagree with the order and sequence of what they're talking about. And that's because I prefer what is listed on this slide. At the very end, coat the sternum on both sides with autopsy gel and preservative powder, replace and realign the sternum with the rib cage, and alternately, viscera may be soaked in cavity fluid several hours before being returned to the cavities with or without the viscera bag. This is what I prefer to do. So at the time we begin the embalming, we take the viscera bag out, we put it into a 5-gallon bucket, we take a large pair of scissors or a scalpel and we slice through the contents of the bag. We don't cut the bag, we're cutting the stuff inside the bag. What you'll then do is you will attach a autopsy aspirator to your aspirator, put it into the bag, and then twist the bag around the aspirator where it is sucking out any fluid that is in there. You're trying to get as much of the fluid out as possible. When you feel that you've achieved as much as you're going to get, turn off your aspirator, open up the bag, pour in your cavity fluid, and very quickly stir things around to distribute that cavity fluid throughout all the contents of the bag. Put your sternum and calvarium in the bag, push down, wrap the bag a couple times to kind of just turn it into a tail. Don't tie any knots. Push it into your 5-gallon pail, and then put a lid on the container and put it somewhere in your embalming room out of the way where no one is going to trip on it. It will then remain in the bucket the entire time that you are embalming with the cavity fluid doing its job. When you are done, you will simply pop open the lid, open up the bag. Again, use your autopsy aspirator to take out all the cavity fluid and now any extra liquids that have been sweated by the tissues. You will add in your powder. You'll take out your calvarium. You'll take out your sternum. You'll add in either more cavity fluid or high viscosity gel. I like to put in low viscosity gel personally, but I've seen people use either low viscosity or high viscosity. I've seen some people put in a half bottle of cavity fluid to make sure there's some more in there. You'll add hardening compound, powders, moisture absorbers, whatever your supervisors or your personal preferences, you will then do with the bag. Now at this point, you will squeeze the bag down, you'll tie a tail and then tie a knot, and this is what you are going to put back in the body when you are done. I do not like just kind of leaving them and then treating them at the last minute. This is the way I was trained. Put it in the bucket, do the embalming for the next hour and a half, 2 hours, and then when you're done, drain everything out, put in what you need to put in, tie a knot, and then place that into the body. Cover the replaced viscera with an absorbent hardening compound before suturing the autopsy trunk incisions. That is if your viscera are just open and not inside of a bag. If they're in a bag, you should put these items inside of the bag. The reason why some people put in don't put in the bag is because should there be an autopsy and someone opens up the cavities and sees a garbage bag or a black plastic bag that looks like a garbage bag in there, that could create a negative impression. The truth is, it is a common thing that medical examiners do is they just put everything into a bag and put that bag where it goes, and a black plastic bag is the most common item used for that. If thick cotton is used to fill the cavities, cover the breastplate in exposed cotton with webbed cotton or Webril. Thick cotton has a tendency to get caught in the needle during suturing, and it is then pulled through the needle holes, which is a problem because that creates a leaking hazard. Bring all 3 flaps together and secure them at central points with gathering forceps. Place bridge sutures every few inches along each of the separate incisions to align the tissue margins for suturing. And you can use a combination of temporary sutures and forceps if you so desire. You see a good example here on the screen where you have a single drawing forceps pulling together here, and then you have other stitches making sure that everything is aligned so that as you suture, things will look okay. Begin to suture using a double curved post-mortem needle and linen suture cord. Linen is much stronger than cotton, and realistically on adults you should not be using dental floss. When pulling on the cord, make sure you pull on the cord and not the needle, because if you are pulling and it is creating tension on the needle in the eye, you're going to fray the cord and it is going to break. Start the suture for the abdominal cavity at the level of the pubic symphysis. Begin the suture by tying the ligature in place or tying a knot on the end of the suture. A baseball suture is recommended for closure. When ligature is visible, the stitches are too loose. Single or double cord suture may be used. A single strand of linen may also be sufficient. Again, it depends on the size of the ligature that you are using. When the hole made by the suture needle appears large, double the thread to fill the void. It is important that you do not leave space where liquid can come out and destroy clothing and casket interiors. Every 4 or 5 inches, pass the needle through the both sides of the incision to lock down the previous suture. So baseball stitch, baseball stitch, baseball stitch, baseball stitch, locking stitch, baseball stitch, baseball stitch, baseball stitch, baseball stitch, locking stitch. So if at any point something should snap, you're not undoing all of your work. If you strike bad luck, the suture thread should break when a lockdown has not been practiced. Pull enough thread to tie a knot in the end and begin suturing with a new length of thread. You could also start from the other end and work your way back down and then tie off at that point. As the suture reaches a bridging stitch or gathering forceps, remove the stitch or instrument and then continue. Upon reaching the xiphoid process, continue the suture up one branch of the Y incision towards the shoulder and end the suturing at that point. Apply incision seal powder as you suture to prevent leakage. The area closest to the shoulder, is the most dependent area and the most likely to leak. Begin another suture from the xiphoid process to the opposite shoulder, and the skin of bodies with wasting disease is difficult to suture because it tears easily. In this case, use a worm suture. So if you have fragile skin, instead of using a baseball stitch, use a worm suture. Following the arterial embalming of the head, various practices may be used to prepare the cranial vault, replace and secure the calvarium, and complete the suturing of the scalp. Calvarium clamps may be used to effectively secure the calvarium in place. The internal surfaces of the cranium are treated with absorbent, drying, and preservative products prior to closure. Remove the absorbent material placed following the cranial autopsy. They typically put a sponge or an absorbent pad in there. Aspirate any of the remaining liquids, dry out the area. Brush the walls with autopsy gel. Place incision seal powder followed by cotton into the foramen magnum. Add absorbent compound. Pack the entire vault tightly with cotton. Brush glue on the margins of the calvarium and the margins of the skull and replace and align the calvarium. So what you see is in the upper left-hand corner here, you see that absorbent pad that they were talking about. Next, you can see they have kind of dried out everything in that open scalp. Finally, they have packed the foramen magnum with some cotton and put in some absorbent material, looks like sawdust or cellulose. Finally, they pack the entire orbit with cotton. They take glue, they apply it to the entirety of the calvarium, and then they put it back in place. Then says to suture through the temporalis muscles, apply mortuary putty along the seam where the bone of the skull meets the calvarium. Continue with a coating of putty over the entire calvarium. Reflect the scalp to its original position, fully covering the calvarium. The scalp will adhere to the mortuary putty and hold the calvarium in place. Prior to suturing, wet the hair and apply hair conditioner. Use a comb to direct the hair away from the incision. Elastic hair bands or barrettes can be used to hold longer hair out of the way. So what you see here is an excellent way to suture the scalp. Trim the hair with barber shears closely along the margins of the incision. This ensures a clean suture closure by preventing the needle from pulling individual hairs through each suture. The hairline meets the suture. The hairline meets after the suture is completed. Combing the hair will hide the incision entirely. So on the topmost pictures, you see that we have cleaned about a 1/2 inch to 1 inch margin. It looks like from the incision to the normal to hair, to where the hair is. Then we use that as a guide to make our suture. When we pull it tight, you can see the worm and suture is pretty well closed everything. And then when we comb the hair back and over, we won't see anything. You have an example of doing the same suture on a person with much less hair. You can see the type of suture it forms afterwards. And this is easily filled with mortuary wax, which you can then cover with cosmetic and blend into the natural skin tone. So it is relatively hidden. You do need time, okay? You do need time to be able to do something like this. This is not something that's done in 30 to 40 minutes. Begin on the right side of the head, anatomical right, and complete them on the left. The direction of suturing ensures that any puckering that may occur from the slipping of the scalp tissues will occur on the left side. Trim the hair with, went back the wrong way. Suturing the cranial cavity. Using a double curved needle, tie the first suture into place behind the right ear. Avoid knots as they have a tendency to pull through the scalp and tissues. The inversion suture or the worm suture is made entirely on the surface of the scalp. At completion, the line of closure is flat, tight, and leak-proof. Suture thread should not be visible. This type of incision is easily concealed with cosmetics or waxes. Man, I have a lot of spelling errors on this. Something tells me this might be an older version of this PowerPoint where I did not make the additions or make the corrections. A baseball stitch can also be used. A greater incidence of damage exists when suturing with a baseball stitch, especially on fragile skin on the scalp. As the thread is pulled tightly with each pass of the needle, the marginal tissues may tear. In other words, you'll pull through the skin and rip a vertical line through it rather than just creating a hole. Baseball sutures will produce a visible tissue ridge after completion, and it is not ideal on a head without hair or when the autopsy incision is made nearer to the forehead, as it is not easily concealable. Now, this is really important because in the 5th edition of the book, it really advocated using a baseball stitch rather than an inversion suture. Superglue is also an alternative to sutures for scalp closure, especially for infants and young children. It is advantageous for the preparation of infants and for tissues that may be easily torn during suturing. Superglue is also beneficial to repair extraneous scalpel marks caused during cranial autopsy. It's a fancy way of saying if you have a couple of scalpel nicks because someone was a bit heavy-handed with the scalpel, you can put some superglue in there, pinch it shut, and problem is solved. After suturing the cranium, wash the hair to remove blood, mortuary putty, and loose hair, then towel dry carefully. You don't want to play around and articulate a lot up here because you can do damage. Bathe and dry the entire body and cover sutures with glue and strips of cotton like you see here in this picture. Dress the body in plastic garments and place powders and preservatives as needed to control condensation, leakage, and odors. So with partial autopsies, the order for treatment is determined by the judgment of the professional embalmer and based upon factors and individual conditions discovered during the embalming analysis. When the autopsy reveals a pulmonary embolism, the pathologist may trace the origin of the blood clot. Exploratory incisions are often made along the medial and posterior areas of the lower legs. These incisions can be packed with cotton inlays and saturated with embalming chemicals while the body is being embalmed. Remove the inlays, replace with dry cotton, and apply mortuary putty during suturing. Incision seal powder will spill from the posterior incisions. A baseball suture is recommended for the length of these incisions. Cover completed incisions with glue and cotton, and plastic stockings are advised when incisions are on the dependent areas of the leg. So what if you have a death with overdose? The post-mortem examination may involve, push a little button here, check something out. The post-mortem examination may involve tissue excision of keloid scars or fibrous tissue formed from the repeated use of hypodermic needles in the same tissue area. The size of the sample tissue removed may prevent suturing of the area. Cover the area with a saturated chemical compress during embalming. Dry that area with a hair dryer and cover with glue and cotton. Use a plastic garment over the area. So cranial autopsies, both of these are a take on a restricted cervical injection. This method is essentially, the cranial autopsy method number 3 is essentially a femoral injection, and you clamp the arteries leaking in the head. So what they're referring to is, in the pictures in the book, you'll see that there are 2 small arteries that come out right about here. Right about here. And what will happen is you will inject from the legs, because the entire body is whole. The only thing they opened up was the cranial cavity, and they took the brain out. So you open this up, you inject, and this is inevitably going to leak. And what you do is you simply clamp off those arteries right around here so that it builds up pressure and it distributes normally. With the thoracic cavity autopsy, in method 1, you're going to utilize the aorta. In method 2, you're going to use the legs, and then tie off the aorta as it starts to leak. After injection is complete, you can use supplemental treatments and then brush the thorax with autopsy gel and fill with absorbent material. Saturate the cavity before closing with a baseball suture, and then complete cavity aspiration is accomplished externally from the standard trocar site. With the abdominal cavity autopsy, the abdominal only, you will inject utilizing the aorta, which, notice a trend here, use the biggest pipe you can. Method 2, you'll use the carotids to inject and tie off the aorta as it starts to leak. In both, you need to inject what you can find in the pelvis, preferably the internal, external iliacs or their remnants, and then perform supplemental embalming as necessary. The walls of the cavity can be brushed with autopsy gel and the abdominal cavity filled with absorbent material. The material can be saturated with cavity chemical or other preservative chemical before suturing. Suture the abdominal incisions using a baseball suture. After washing and drying of the body, glue may be applied to seal the incisions. Aspiration and cavity fluid injection of the thorax can be effective either through the diaphragm or by inserting the trocar through the rib cage. If aspiration and injection are to be done through the external rib cage wall, this treatment can be done before or after the autopsy cavity has been closed by suturing. So facial trauma. Restoration of the deceased to a natural appearance is one of the primary functions of embalming. Restorative treatments begin in the pre-embalming period and continue throughout embalming. The majority of restorative work is routinely accomplished in the post-embalming period. The following outline suggests the order of preparation for autopsied bodies that have sustained facial trauma. 2 criteria must be met for effective tissue restoration. The tissue must be firm, and the tissue must be dry. The basis for all restorative art. The basis for all restorative art is clean, dry, well-embalmed tissue. Period. In addition to the presence of trauma, other post-mortem conditions must be considered. Facial trauma will necessitate a strong arterial solution to control swelling, dry, and firm tissues. A moderate strength solution may be desired for the extremities. Use the right tool for the right job. If you have a lot of facial trauma or some facial trauma and swelling is anticipated, you will want to involve a very strong, fast-firming chemical for the head. There is nothing that says you have to use that for the rest of the body. So once again, sanitize and position the body. Assess damage to all body areas. Begin with injection of the legs and then inject the arms. Prepare the head and face. Open the cranial cavity, inspect for bone damage, inspect the scalp for lacerations or abrasions. Inspect superficial tissues of the face for punctures, lacerations, abrasions, and hematomas. Debride loose skin to expose undamaged tissue. Dead skin has to go. You can only work with regular skin. So if you see skin slip, you see top layers coming off, you have to get rid of all the damaged and dead skin. Excise dehydrated margins of lacerated tissues with a razor or scalpel to expose undamaged tissues. Apply digital pressure to the surface of the face to inspect for fractures of the mandible, maxilla, and nasal bones, and for the presence of subcutaneous emphysema. Perform mouth closure. Temporary glue the lips to maintain natural closing. Set the eyes using cotton or eye caps. The lids may be glued prior to injection. And fill depressed fractures with mortuary putty or mastic compound. Align your lacerated tissues. Temporary bridge sutures using dental floss or super glue can be used. After embalming, remove the temporary sutures, align the tissues, and apply glue. Prepare a strong arterial solution using a high index fluid. Add dye to the arterial solution to serve as a tracer. Inject the left side of the face first using instant tissue fixation. Pulse solution repeatedly until the tissues firm. Stop if swelling begins. Repeat with injection for the right side. A great volume of solution may leak from damaged tissue areas. Leakage will actually reduce the tissue swelling. Slow and steady wins the race. You do not need to rush this, and you cannot rush this, or you will get spectacularly bad results, which may lead to liability and trauma, psychological trauma from the family. So, folks, that wraps up this lecture. We will see you next video.